the purpose of me giving the talk is not to give you any answer, but rather to stimulate the discussion, and I think we have succeeded in doing so. So this is going to be the same formats. I'm going to talk a little bit about the primary extradural osseous spinal tumors. We'll also start with a case like this. 35-year-old banker, low back pain for 9 months, continuous nocturnal pain, relieved by NSAID. And the plain radiograph, the first plain radiograph was passed by the GP as unremarkable, and he was sent home. So he had this back pain for 9 months until he was seen by an orthopedic surgeon and had this CT scan done. I'm sure we can all see that lesion in the on the left posterior element, very nicely circumscribed, sclerotic margin, clean, the transition shown is very clear, and with the sclerotic leaders in the center. So I think the diagnosis is very obvious. Even our medical students should be able to make this diagnosis. And the MRI shows a reaction, soft tissue reaction around that tumor, but this does not mean that this is pathological, but this is simply reactive changes and around that lesion, which we all know this is an osteoma. So I think most of you would either do a radiofrequency ablation, but in this case, because it's closer to the facet joint, and our radiologist thought that it may be difficult to insert the radiofrequency probe, so we decided to do a small laminotomy over that facet area, preserving the inferior articular facet, and we took out that leaders, which is very nice, and complete resolution of symptoms. So this is a benign, very benign condition which can be treated with an intralesional excision. The next case is a 37-year-old computer programmer, neck pain for 2 years, no neurological deficit, but only neck pain. He has a vague palpable mass at the C5-6 on the left side, but otherwise he has full range of motion of the neck, no neurological deficit. This is the X-rays on presentation. Blood parameters normal. The PET scan was done by a referring doctor before it was sent to us, and the patient has a solitary lesion at the C5-6 area, and X-ray of the C-spine shows an expansile lytic lesion on the left side of the C5 and 6 facet joint. It mainly affects it appears to be affecting the L5, the C6 posterior element, possibly also involving the C5. And the CT scan showed a destruction of the an osteolytic lesion, and also a lot of pneumosclerotic changes. There's an osteolytic center. There's a small component anterior to the facet, but it's not causing any neurological deficit. Okay. And the MRI again showed after gadolinium enhancement, there's significant soft tissue enhancement. Also involvement of this adjacent C5 and C6 lateral masses. And so the MRI changes on the T2 weighted axial image, showing also the posterior soft tissue component here, also a reactive change. And the percutaneous tumor biopsy was done in osteoblastoma. What would you do? Involving 2 adjacent lateral masses, a benign condition, but it's actually slightly extensive. What would anyone do? Excision, curettage. Anyone would want to do a curettage? Anyone would want to do a radical excision? Radical excision, meaning we have to excise the whole vertebral body or the 2 vertebral bodies, or we do an curettage or intralesional excision. Intralesional excision. Okay, that's what we planned to do. We planned to do a marginal excision, meaning, of course, in the spine you can never get a radical because you're close to the the dura. But in any case, this is a benign condition, so we do not think we need to do a radical excision as such, meaning they have excised the two vertebrae completely. So we decided to do a marginal excision. Of course, osteoblastoma is going to be very vascular, so we decided to do a preoperative embolization and look at the feeding vessels first. And intraoperatively, we had to excise both the facet, the whole of the C6 facet, because it's involved. So we did a hemi, we did the combined anterior and posterior approach. We excised half of the vertebral body of the C5 and C6, and also the whole of the C6 lateral mass in the facet joints, and also the C5. So we had to do fusion across these segments, both anteriorly and posteriorly. So we combined anterior-posterior marginal excision of the tumor, C4 to C6 put anterior, and C4 to C7 instrumentation posterior. And the patient has got complete relief of symptoms, and follow-up at 5 years, there's no evidence of recurrence. So this is for benign condition. This is case number 3, a 15-year-old female, young girl, upper thoracic back pain for 2 months, pain over the interscapular area, and decreased sensation below T4. She presented with also acute onset of bilateral lower limb weakness, and the lower limb motor power was around 3/5. Sphincter function were intact. Acute neurological deterioration. And the plain X-ray and the MRI showed the lesion at T2, thoracic 2, and also destruction. You can see the loss of the pedicles image on this side. And there's a significant soft tissue component with intraspinal compression also involving the posterior elements. So I think on imaging we all agree this guy looks much more malignant than the previous 2. On the MRI it shows a pathological fracture of the vertebra, significant soft tissue component, intraspinal extradural extension, and also you can see the extension into the upper mediastinum. So it's starting to develop some root signs involving T1 root. Again, unfortunately, she was admitted to a pediatric department in another hospital elsewhere, initially treated by a neurosurgeon and pediatrician, and their decision at that time was to do a biopsy. And then because they believe this is more likely to be a malignant tumor in a child, and they thought Ewing's sarcoma is the top on their differential diagnosis, so they started the patient on chemotherapy of Ewing sarcoma chemotherapy protocol. Unfortunately, the biopsy returned to be giant cell tumor instead. And that's the time when the patient has already been started on the chemotherapy for Ewing sarcoma, and the patient was then referred to the orthopedic surgeon. While the patient was waiting for transferal, in fact, the patient had some recovery of her neurology with the chemotherapy. And then the neurologists and the pediatricians were very excited. And they said, no, the chemotherapy is going to work. Obviously, we do not think it that way. So by the time the patient came to us, 1 week after chemotherapy, there was apparently good response, but there's still a little shrinkage of the tumor on the MRI and the CT. Initial slight improvement of motor from 3 to 4, and transfer to our hospital, and our plan is to go for a radical excision, because I think in giant cell tumor the primary mode of treatment is a radical excision. You must try to remove the tumor in the first attempt. So we planned for a wide marginal excision. We want to call it a radical excision, but by definition it cannot be radical again. So we want to do a wide marginal excision, meaning a total vertebrectomy front and back. And preoperatively, we started her on the preoperative Somita, which is anti-osteoclastic activity agent. So it has been shown that it can reduce or increase the tumor's necrosis rate before the surgery. But while she's being put on the Somita program, she has further neurological deterioration, and we had to jump in and do surgery early. So just before the surgery, we repeated the MRI, and it's already a significant increase in size of the tumor again, which is not unexpected because we know this is not the Ewing sarcoma, and this is a giant cell tumor, which involves also the pleura on this side and also the rib head on this side, encroaching onto the T1 and the T2 nerve roots. So we try not to sacrifice the T1 roots because it's going to affect her hand function quite significantly. We try to best to preserve the T1 root function if possible, but that would also compromise our surgical excision margin. Right, so your preference. Chemotherapy, I don't think anybody would use chemotherapy for GCT. Radiotherapy, no. Intralesional curettage, this is what you would do. There's an option if you have a giant cell tumor, you can curettage the giant cell tumor. But in a spine curettage of the giant cell tumor, you've got a very high recurrence rate, and if it recurs, it's very difficult to treat. So we decided to do a wide excision. You would want to do it piecemeal. This is combined the anterior and posterior element involved. Technically, it would not be easy, but we'll try to do a total vertebrectomy. So again, we did the preoperative embolization, and this is the total en-bloc vertebrectomy. Actually, the part of the pleura was also excised, including the second and the third rib. And this is the intraoperative photo showing the ligation of segmental nerves, and then it's a total anterior posterior, a single stage posterior alone, total en-bloc vertebrectomy. And this is after reconstruction with the cage and also posterior instrumentation. Another young patient, 14 years, bilateral lower limb weakness for 2 months, unable to walk for 1 week, and decreased sensation from T8 down, lower limb power 3/5. Blood parameters normal. X-ray showed a collapsed T8, left T8 pedicle destruction. MRI, high signal intensity signal over the vertebral body of T8. Extradural soft tissue involvement, also posterior column, posterior element involvement with cord compression. PET scan, solitary lesion at T8, no evidence of other metastasis. The CT-guided transpedicular biopsy returned to be hemangiopericytoma. Fairly malignant tumor, fairly rare condition, but a fairly malignant condition in a child, 14 years old. So what would you do? Diagnosis confirmed, hemangiopericytoma. with cord compression, only lesion on the PET scan. Chemotherapy? No. Radiotherapy? No. Sorry, say that again, Professor. Okay, radiotherapy if the service is available. Intralesional curettage is a malignant condition, so we probably would not offer an intralesional curettage. And in this case, again, we tried to do a wide margin excision, and again, we decided to do a total vertebrectomy, en-bloc T8 vertebrectomy. And this is after reconstruction, bilateral, together with the pleura on both sides, reconstructed of the pleura with the mesh. Wide margin excision, reconstruction after en-bloc vertebrectomy, T5 to T11 instrumentation. So hemangiopericytoma, by the way, is a very rare tumor. It's up in less than 1% of the malignant tumor of the bone. The biggest series reported in the Mayo Clinic is only 15 cases, but this is just an example to show how we should manage, in principle, a malignant condition in the spine. And I think most of us would have forgotten our histology, but it's actually very important that we should, as orthopedic surgeons, we are not just technicians, we should also remember the histology. This is this typical, what we call the staghorn shaped blood vessels in the hemangiopericytoma, the staghorn of the deer. And this is the recommended treatment in the literature. Low grade, if it's a relatively low grade hemangiopericytoma, you can do a wide resection. If it's high grade, it should be followed with supplement chemotherapy, radiotherapy post-operatively. So these are the common benign tumors of the spine: hemangioma, eosinophilic granuloma, osteochondroma, osteoid osteoma, the larger version of osteoid osteoma, the osteoblastoma, irreversible bone cyst, and giant cell tumor. Giant cell tumor is considered a benign condition, but it's called a benign aggressive condition. So it should be treated more like a malignant condition. And the principle of management for benign condition, I think we all know we can afford to do either intralesional excision. Primary malignant tumors of the spine is actually not that common, but it has 5% of the malignant musculoskeletal tumors. Most of the tumors in the spine are metastatic tumors, and primary tumors is less common. Symptom-wise, of course, they give rise to pain, neurology, and of course the confirmation by histology. Primary malignant tumors of the spine, the common ones are myeloma in the elderly, plasmacytoma, lymphoma, chordoma in the upper and the lower ends of the exoskeleton, the osteosarcoma, chondrosarcoma, and Ewing sarcoma, particularly in children. And in fact, as we mentioned, giant cell tumor, some people would actually put it somewhere between these two groups. The principle of management, you still classify or want to stage the tumor and grade them into low grade, high grade, or whether there are distant metastases. And the principle is actually very similar to limb surgery in that you have to do intra or extra compartmental. The only difference in the spine is that you can never do a complete radical excision because you have to preserve the spinal cord. In certain cases, we have actually excised the dura together with the malignant tumor, and we have reconstructed the dura during the same setting. But still, the margin will be very small, and you cannot really call it a radical excision. And this is the chart that recommended by Dr. Tomita in Kanazawa in Japan. Depending on the location of the tumor, whether it's in the anterior element, anterior together with pedicle, or anterior and posterior element, there's different ways of the excision of the tumor. There's intracompartmental excision, extracompartmental excision. When there's skipped lesions, these are called. This is classified as skipped lesions. So if you read Tomita's article published in 1997, that's a good description of under what situations you can afford to do total en-bloc vertebrectomies. I think the largest number of segments that we have excised is 5, and 5 segments, and the patients could be kept neurologically intact with 5 levels of en-bloc excision. So with that principle, thank you for your attention. I'd like you to discuss this further. Thank you.
Thank you, Kit. Any points of discussion?